Hello and welcome to the fourth webinar in our Transition to Transplant series. Today we have Pencharz and Brooke Stewart here with us to speak about gastrointestinal issues and nutrition in cystic fibrosis. There'll be some time at the end of the session for questions, and you can either type your questions in the Q&A box located on the bottom right of your screen, or you can use the raise the hand feature in WebEx, and I can unmute you so you can ask your questions over the phone. Paul and Brooke, thank you for joining us today, and I'll pass it over to you to start today's talk.
Service at Toronto General, and we're going to share with you some of our perspectives that will help you look after patients with GI and nutrition issues who are undergoing transplant. Well, supposed to move on. There we are. So a fundamental problem that was evident long before we started doing transplants was that marked malnutrition occurred in most adolescents and adults with cystic fibrosis and end-stage lung disease. And it was evident that this was due to adverse energy balance, and we set about trying to understand how energy balance was affected because it would allow us to do something. When the CF gene was discovered, it was, and we then understood what CF transmembrane regulator was all about. We realized it was an energy-expending process and thought that perhaps there would be some effect on basal metabolic rate. Or it might be something due to sodium transplant, which might expend additional energy. However, there were some studies then from Australia that showed that CF patients who have minimal lung disease do not have increased resting metabolic rate, and rather the resting metabolic rate increases as cytokines are released into the bloodstream associated with worsening lung disease. So as the as lung disease gets worse, so resting metabolic rate goes up. And of course, in 85% of patients with pancreatic insufficient, maldigestion, malabsorption adversely affects energy balance. This thing is sensitive. There we are. Now, it's important to realize that just anorexia or starvation-induced malnutrition is a process in which adaptation takes place. The basal metabolic rate decreases, there's conservation of body protein, and so on. However, in cytokines, that's all upset. The basal metabolic rate is increased, protein preservation is lost, and so there's quite a catabolic process. We then set about looking at saying what were the different factors that resulted in an energy deficit. Was it increased needs, and we've talked about that in terms of increased cytokines. Was it increased losses due to pancreatic insufficiency? Sometimes it was due to behavioral problems in the patients. So there were iatrogenic effects as well, because it used to be thought that because CF patients had problems with fat digestion, we would restrict their fat intake, but a low-fat intake is like a diet, and they, in fact, only take less calories. Anyway, energy deficit, weight loss, which then affects respiratory muscles, lung parenchyma, immune function, and it becomes a vicious cycle, resulting in the patients getting sicker and sicker. So the interventions that were undertaken, the first was by Doug Crozier at Sick Kids in 1970, and he just said we must stop restricting fat and rather use high fat. In fact, it's not a high fat diet, it's just a normal North American 40% of calories from fat. And it resulted in near normal growth until lung function fell. Although dietary supplements are widely used, when we studied this prospectively, we found all it did was displace food calories. And really, if you're intervening, you need your clinical dietitian to work on increasing the fat content of the diet. This darn thing doesn't, and there it's moving again. There were short-term studies with nasogastric tubes and with TPN. They both improved nutritional status, but all gains were lost once the intervention was stopped. So we moved to long-term studies. We in Toronto introduced G-tubes. In Ottawa, they used GJ tubes, and long-term supplemental tube feeding resulted in much improved. We found that the nighttime feeding reduced the intake by about 20% during the day, but the total was increased in 24 hours by 30%, resulting in improved nutritional status. IV lipids, we've also used. It allows easy administration of supplemental energy, but only as an appropriate strategy if dietary protein is adequate. Full parenteral nutrition is needed if the intake is insufficient and if NG tube feeding is not tolerated. I'm now going to change gears when the slide decides it's going to change for me. There we are, to GI issues. So, gastroparesis. This is a major problem that we find following lung transplants, and it's mostly due to damage to the vagus nerve. Since it generally recovers, we regard it as bruising rather than cutting of the nerve. There's also the observation that CFTR appears to affect intestinal motility. We're seeing more and more adults in their 40s who have more and more severe intestinal dysmotility. Then, of course, there's the dehydration of luminal contents caused by the defective CFTR, which results in this process that we call distal ileal obstructive syndrome, combined with constipation. But as it produces obstruction in the bowel, it may worsen things by causing small bowel bacterial overgrowth, which sometimes requires antibiotics. So, I already mentioned DIOS, or distal ileal obstructive syndrome, and it is, as I mentioned, associated with constipation. Prevention and treatment of DIOS, the advent of polyethylene glycol 3350 has transformed the management by allowing bowel hydration, but often we may need motility agents as well. Proximal motility agents working on the stomach and the duodenum are domperidone and cisapride. Distal, such as prucalopride. More recently, we've gone back to the old one of Senecot, which has been around a long time. Now, there's been a worry about whether patients with CF have an increased risk of cancer. And they do, but only as it affects the gastrointestinal tract, pancreas, and hepatobiliary system. So, and it appears to be related to the CFTR, defective CFTR function. And so it's luminal and mucosal cancers which are increased. Immunosuppression adds risks, especially of small bowel lymphomas. So we feel there's a very low threshold for the implementation of cancer surveillance, generally an abdominal CT with contrast, upper and lower endoscopies. Colonic cancer is more frequent following lung transplantation. I will point out that occasionally full-thickness biopsies are needed to detect bowel lymphomas. So you pick it up on the CT, and then if it's not something you find on an endoscopic biopsy, you may have to do a full-thickness biopsy. for hepatobiliary tumors and abdominal CT and ERCP may be needed, and then also MRCPs may be a less invasive screening tool. Abdominal ultrasounds in our hands are not sensitive enough, and so we don't rely on them. So we're on to nutrition issues, and my colleague is taking over.
Yeah. So as a dietitian, seeing these CF patients while they are hospitalized around the time of transplant, the biggest issue, nutrition issue I see, is simply providing adequate nutrient intake while they are ill and in the hospital. In a recent study, the Canadian Malnutrition Task Force found that in Canada, 45% of people in general who are admitted to hospital are malnourished at the time of admission. And they also found that barriers while they're hospitalized, like missing meals for procedures, meal times being interrupted by staff, and being NPO for tests, can be a further barrier to adequate intake while they're there. So those are kind of general things that happen when anyone is admitted to hospital, but specifically with CF patients, when they are at our center for transplant, I see some specific barriers to their intake, and these are all kind of interrelated. So one is simply that our, at TGH, in transplant, is not a specialized CF unit. So the CF patients that are admitted at any one time are a very small percentage. I just took kind of a snapshot of our patient census last week, and there were 70 admitted multi-organ transplant patients, 26 lung transplants, and only 2 cystic fibrosis patients. So this leads to the next point, which is because these are not our main focus on the MOT ward, there is a lack of awareness that the healthcare staff may have about how much these patients really need to be eating to meet their high energy and fat needs. Often I hear that a patient is eating well, and it might look like they're eating well compared to others on the unit, but they're not really coming close to meeting their needs, and their nutritional status can decline quickly. Another barrier is the limitations on the hospital food that we can provide. It's often difficult to meet patient and family expectations. And in our adult hospital, the default food items are often lower energy and fat and smaller portions as well. And then I do find that the cystic fibrosis patients have a history of being hospitalized often and kind of a dislike of or a negative association with the hospital food, which also makes it difficult. And right around the time of transplant, patients may be intubated and not able to eat orally at all. Or after transplant, they may have difficulty swallowing or dysphagia due to prolonged intubation, and then they may require texture-modified diets, which also can make it hard to meet their nutritional needs. So this is just an example I put together of what might be a kind of a comparison between a CF patient admitted at a CF center versus on our transplant unit. So I know at St. Michael's Hospital, they have kind of a CF diet that these patients would routinely would be ordered for them while they're in the hospital. So it's a high-fat, high-energy diet. Snacks are always included, and then patients can add extras. So the minimum is 2,500 kilocalories per day, and often it's more than that with the extra foods they add. Whereas if a patient is admitted to our unit and just a DAT is ordered, that's less than 1,800 calories, and less if other restrictions are entered, like a diabetic diet or a renal diet. So if the dietitian is aware, they can make some adjustments to increase the calories that are provided. So we have a high-energy, high-protein diet, which will provide up to 2,400 calories, and even better if we can add supplements and adjust things. So this, again, interrelated with some of the other things, the dietitian may not be aware of the admission, but there's a lot that can be done if they are aware. So in the period right around transplant, so before and then short-term, in the short term after transplant, we may need to use other strategies to help patients meet their nutritional needs, even if they typically eat enough to meet their needs. So some strategies, we will use nutritional supplements, encourage family and friends to bring in preferred foods, and we are often using, especially after transplant, NG feeds or G2. And as Dr. Pencharz mentions, we sometimes use IV lipids or total parenteral nutrition. And other nutrition issues that arise around the time of transplant are some blood glucose management issues. So for several reasons, this can be a little more complicated in hospital around the time of transplant. And this is true in patients with CF-related diabetes and those who have not had diabetes in the past. So different diet and activity levels while in hospital, having their medical team or the endocrinology team manage their insulin where maybe they were used to doing that at home can complicate things a little bit, as well as steroid medications and enteral feeding. So typical diet restrictions that we would normally suggest to patients who have hyperglycemia after transplant may not be appropriate, and that would be another time it would be great if the dietitian was involved. So some other sort of GI issues that Dr. Pencharz mentioned, so bowel regularity or constipation. So I'm just kind of addressing this from the point of view of the dietitian on the unit, just being, that would be pay extra attention to kind of what's going on in terms of the patient's bowel movements and being proactive with the bowel routine and specifically using the PEG formula versus other types of laxative medications. And in terms of gastroparesis, so medical management is what we've seen to be effective, but for the dietitian, just being aware of how much the gastroparesis may be limiting the patient's intake, and the diet recommendations to optimize gastric emptying need to be balanced with making sure the patient gets enough calories overall. And then we have used NGJ or GJ tubes in patients who really are struggling to meet their needs when they have severe or prolonged gastroparesis. And finally, enzyme administration is sometimes a bit tricky while the patient is admitted. In our hospital, we don't always have the same dosing and brands of enzymes that the patients are used to taking at home, and we may need to kind of use trial and error to find out the best timing and dosage while they're on enteral feeds, especially if that's continuous enteral feeds.
So that...
One more.
Oh, sorry, one more slide.
Yes. So this is just thinking of CF nutrition issues in the long term after transplant. So working to gain weight or maintain weight, which might have been what the patient was working on for much of their life, may no longer be the priority. Weight can increase dramatically in the first year after transplant due to decreased work of breathing, the steroid medications increasing appetite, and better overall health and appetite. But some of the other issues that might come up are new diabetes or steroid-induced hyperglycemia and gaining too much weight. We do see that sometimes with our CF patients. So the shift for the dietitian might change from just emphasizing quantity of intake to looking at quality of intake.
So that completes our formal presentation. Are there any questions?
Thank you, Brooke and Paul. So yes, we can open it up for questions now. And again, just to repeat, you can either type questions in the Q&A box on the bottom right of the screen, or you can use the raise the hand feature and I can unmute you so that you can ask questions directly over the phone. So there's a question from Nikki Asset. I've unmuted you, Nikki.
Hi. So I'm the adult nurse, CF nurse in Saskatoon, and I find it interesting that you are using the brocalamide as well. Like, we started using that with some of our patients, and it's been actually quite successful. Didn't realize you could use Senecot as well, you said?
Yeah. So it's Paul Pencharz responding. The prucalopride we have, like you have in Saskatoon, found it generally to be quite helpful. But the trouble is that the prucalopride has a mechanism of action that's somewhat similar to cisapride, and there are situations where I want to be able to use cisapride, and I then have to stop the prucalopride, and that's where I've used Senokot in the place of prucalopride.
Okay. We actually are having quite a bit of difficulties with coverage for procalamide because it's so expensive, but we've had patients that actually are paying for it because it is actually working well for them. But I wasn't sure, so you're switching off the cisapride and the Senokot instead of the procalamide itself. Is that right?
No. What I said was, let's say I've got a patient on domperidone and prucalopride, so a proximal motility agent, the domperidone, and a distal motility agent, the prucalopride. And I'm just finding that the overall dysmotility is sufficiently severe that I need to increase the dysmotility treatment. And definitely cisapride in combination with domperidone is a much more effective combination, but there is no literature to support the safety of introducing cisapride and leaving on the prucalopride. So you have to stop the prucalopride, but then I end up with some problems in the colonic component of the sticky, what I call the sticky bowel syndrome. I can treat quite nicely with PEG, the small bowel, but it sort of works not quite as well in the large bowel, and that's where the addition of the motility agent, and we've been trying Senokot with some benefit.
Okay, thank you very much.
You're welcome.
Okay, not seeing any other questions. I think we can end the session there. So I want to, again, thank you, Paul and Brooke. The webinar has been recorded, and it will be posted up on the healthcare section of Cystic Fibrosis Canada's website under the Transition to Transplant tab. In that section, you can also see any upcoming webinars that we've had scheduled, and these will be emailed out to you as well. So thank you to everyone that joined today's session, and enjoy the rest of your afternoon. Bye.
Thank you, Joanna.
Thank you.
Thank you. Bye.